you've probably heard of people having a stroke. And you're probably familiar with the notion that has something to do with the brain, and you'd be right. In particular, it's a rapid loss of brain function because of something strange happening with the blood flow to the brain. And let me show you that in a little bit more detail. And to do that, let's think about the two major types of stroke. There's the ischemic strokes. There are the ischemic strokes. Ischemic stroke, and the other type of stroke is hemorrhagic. And these can also be kind of subcategorized, but I won't go into all of the details there. Hemorrhagic stroke. And if I really just define ischemia and hemorrhaging to you, I think you'll have an idea of how these strokes are different and how they interrupt the blood flow to different parts of the brain. You know from the videos on stenosis and ischemia and the videos on heart attacks that ischemia is a lack of blood flow to certain body tissues. So an ischemic stroke is actually very, very similar to what we saw in a heart attack, except it's not occurring in a coronary blood vessel. It's occurring in a blood vessel in the brain. So let me draw that right over here. Let's say that this is a blood vessel in the brain. This right here is a blood vessel in the brain. And let's say the blood is flowing in that direction. This is an artery. And so you can imagine that maybe there is a blood clot that forms in some part of the brain. Let me do the blood clot in magenta. This blood clot might form because, no, that's not magenta. The blood clot might form because maybe there's a plaque there. Maybe the plaque got ruptured. Either way, this blood clot is restricting the flow of blood. And we know that this blood clot, we can call this a thrombus. Or we could say that thrombosis has occurred over here. Either way, the blood flow is restricted, and the brain tissue that's further downstream is not going to get its oxygen, and it might die. It might experience infarction. And that's why ischemic strokes are also sometimes called cerebral infarctions. Cerebral infarctions. These are all very fancy words, but I think hopefully they're becoming a little bit more common in our vocabulary. They keep showing up over and over again. And I also want to be clear, most strokes are actually ischemic strokes. The numbers I looked up, they say 87%. 87% of strokes are ischemic. Now, the other type of way that you could have ischemia in one of these blood vessels, and it's completely analogous to what we saw in the heart when we had heart attacks, is you could have thrombosis, or you could also have an embolism. Whenever someone says thrombosis or thrombus or thrombi, they're talking about blood clots. Whenever someone talks about an embolus or emboli or embolism, they're talking about something moving through the blood that eventually blocks a blood vessel. So you can actually have a thromboembolism. You can actually have a blood clot that gets broken off. So you could actually, so let me ignore this for now, or let me paint over it a little bit so that this isn't the main cause of blockage. But you could actually have a blood clot that breaks off, becomes an embolus. It becomes an embolus. And since it's an embolus due to a blood clot, you call it thromboembolus. I always have trouble saying all of these words. And eventually, it blocks an artery right over here. So this right here is an embolism. But either way, you're blocking the blood flow further down the brain. It could cause infarction. That brain tissue will die. And whatever that brain tissue did for mental function or whatever is going to make it very hard for this person who's experiencing the stroke to do those things. Now, it's not always noticeable. That's called a silent stroke, but damage is occurring. The person experiencing the stroke, and I'm not a doctor, so take all of this with a grain of salt. The person experiencing the stroke, it could be anywhere from, well, one, they might not even notice it even though damage is occurring. They might have a headache, or it might be more severe. They might actually not be able to properly move a side of their body or a side of their face or properly be able to speak. So it really depends on what part of the brain is being damaged. But in either of these situations, an ischemic stroke is caused by some type of restriction or blockage that causes things downstream to not get proper oxygen. And then, so you can imagine cells over here aren't going to get their oxygen, and that they might actually die. A hemorrhagic stroke, to hemorrhage literally means to bleed. It's literally just a fancy word for bleeding. And so in a hemorrhagic stroke, you have a situation where a blood vessel can actually break. Where you have a blood vessel, I'm trying to draw the same blood vessel, where it actually breaks. And we'll talk more in the future of why a blood vessel might break, strongly related to high blood pressure and other risk factors. Don't want to get into that right now. But you can imagine if a blood vessel breaks, you have all this blood spewing into the brain in kind of an uncontrolled way. So let's say this little diagram I do here, that part of the brain. If you have a hemorrhagic stroke, you have all this blood that's flowing into the brain, and you can imagine all that uncontrolled blood will mess up that part of the brain. It'll cause those neurons and brain tissue to malfunction, and maybe even cause some of it to die. And it would also cause the blood flow further downstream to be impaired. So the stuff downstream aren't going to get the blood they need because all of the blood is being released everywhere else. And since 87% of strokes are ischemic strokes, the remainder are hemorrhagic. So this is the remaining 13% of strokes.
But I want to talk about something a lot of you have been talking about, this moment that shocked so many when you were watching Sunday night's game between the Texans and the Colts. It didn't actually happen on the field during play here. It happened right before halftime when Texans head coach Gary Kubiak collapsed. You can see it on the field. He was walking to the locker room. People rushed in. What was going on? We can tell you that he was released from the hospital today, and the cause of this was a mini stroke. Senior medical correspondent Elizabeth Cohen is here with me. It's scary to see what happened on the field. People were like, what happened? We now know. What is a mini stroke?
So a mini stroke is really just that. It is a mini version of a stroke. And so let me show you what I mean by that.
Okay.
Now, we don't know where exactly Coach Kubiak had his mini stroke, or TIA as it's called, but it's somewhere, in this system. So let's take a look close up at a vessel. So blood is running through this vessel, right? That's the way it's supposed to work. When someone has a stroke, you get a clot at some point, and so the blood can't keep flowing to the brain.
Okay.
Now, in a full stroke, that clot stays there until medicine or something else gets it out, and that's a really dire situation. In a mini stroke, it kind of breaks up and breaks away on its own. So it just sort of goes away. And so it's a very different kind of deal than a full-on stroke.
So if you have a mini stroke or a TIA, what's the prognosis for the person afterwards?
The prognosis is great. I mean, many people have no symptoms after they have their initial set of symptoms. We saw the coach was on the ground, but many people are just perfectly fine afterwards. But there's a big but.
Okay.
And that is that someone who's had a mini stroke is 10 times more likely to go on and have a full-on stroke.
Oof.
So that's pretty serious. I mean, people who've had mini strokes need to know that they need to really be wary about this.
So what can someone do? I guess even especially when could be in the middle of it, what does it feel like? What are the signs?
Right, there are certain signs that you should look for, and it's important for all of us to know this because you never know when you're going to be with someone who's going to have a stroke or have a mini stroke. I mean, they need medical treatment either way. So these are the signs from the American Stroke Association. Face drooping, arm weakness, both of those would be usually on one side.
Okay.
Difficulties with speech, and that means it's time to call 911. So F for face, A for arm, S for speech, time to call 911.
Fast.
And don't hesitate, because there's a window in which you can get treatment, and you need to meet that window.
Okay, Elizabeth Cohen, thank you. We wish
Thanks.
the coach a quick, speedy recovery here.
Transient ischemic attack is the technical term for a transient blockage of the blood supply to the brain. We usually use the term TIA because it's easier for people to remember. Many patients describe this as a mini stroke. It's important, though, to understand that this is not a minor problem and really should be regarded as an emergency that needs to be dealt with very, very quickly, because patients are at very high risk of going on to having a completed stroke, which can lead to devastating disability.
The first symptom was the feeling of going to faint, and this very hot feeling that kind of whooshed over, very quickly followed by the numbness down the left-hand side, which you really truly, I could have drawn an absolute line down the middle. Everything on the left, legs, arms, head, toes, everything went completely numb. That passed, probably lasted about 10 minutes. And you just sit there and think, what was that? It's very odd. And I didn't associate it with anything. I didn't immediately associate stroke symptoms, I must admit. So did nothing about it.
Symptoms of a transient ischemic attack, or TIA, usually last less than an hour. For most patients, it will only be 10 to 15 minutes.
Well, the second one was the next morning, and it was much more minor, more mild. And I thought about it during the day, and I thought, no, that's the second sort of episode of that. I think I ought to make an appointment with the doctors. But again, thought I'll do that next week. It was bank holiday weekend. It's never a good time with the doctor, is it? So I thought, no, I'll leave it. It's not urgent. I'll leave it. A&E. Well, the third one was the same again, at my desk, almost the same time of day, 4:30 in the afternoon, almost identical. The same feeling, the same symptoms, the same numbness, the same feeling of going to faint, hot, prickly. And I thought, no, I really have got to do something about this time. I really must.
There are several different symptoms, but it's quite useful to use an acronym called FAST to help patients to remember the symptoms of a transient ischemic attack, a TIA, or a stroke. The F stands for facial weakness. So the patients may have drooping from the corner of their mouth, they may dribble from the corner of the mouth. A stands for arm weakness, so we ask patients to hold their arms up, and if one of the arms can't be held up, then they've got weakness. S stands for speech disturbance, so they may have slurred speech, or they may have unintelligible speech. And T stands for time to call for help, because this is a medical emergency, it needs to be dealt with straight away.
Well, in A&E, I saw a triage nurse who again took down all my symptoms, and actually saying them out loud made me realise kind of what had happened to me. So my diagnosis was almost being confirmed in my own head as I went along, but the hospital did also confirm it.
Patients are most likely to be affected if they're above the age of around 55, and then the incidence becomes much more common in the elderly. But in fact, TIAs can occur in much younger patients, and so everybody needs to be aware of the symptoms of a TIA.
I'm very shocked because there's no family history. I don't have high blood pressure. In fact, my blood pressure at that point was usually quite low. I didn't have a particular cholesterol problem. I know I carry a bit too much weight, but nothing that anybody seemed to worry about. Fairly fit. I was completely shocked by it, really, the fact that it could happen to me, which is perhaps why I denied it in my own mind to start with.
There are a lot of other symptoms that can mimic a TIA. And so the first stage is to be sure that it is truly a TIA. And then the second stage is an assessment of what's caused the TIA. For example, is it primarily a problem related to the heart rhythm, or is it due to abnormalities within the blood, or is it due to abnormalities of the blood vessels? The majority of patients, a combination of treatment for their blood pressure, for their cholesterol, and drugs to thin the blood will significantly reduce the risk of them having a stroke.
The basic three things, really, I would say. One, it can happen to anybody at any time. Secondly, be aware of the symptoms, and hopefully the television campaign and poster campaigns help that. And thirdly, get help, and get quick help, because I took myself to A&E, which meant I had to sit there for 4 hours and have another one in the waiting room while I was waiting. If I perhaps had called 999 and got an ambulance, maybe I would have been slightly more fast-tracked and dealt with differently.
The reason why we think it's important that patients with a TIA seek help immediately is that within the next 1 week they have an 11% chance, so roughly 1 in 10 chance of having a completed stroke. And if we can intervene in that first week, we can reduce quite considerably the risk of them having a stroke. If it's beyond a week, they still have an increased risk, so that by a month, between 15 and 20% of patients will have had a completed stroke.
After you start to recognize that someone might be having a stroke, right? Maybe they have some of the symptoms we know to be common stroke symptoms, like maybe one side of their face starts to droop, or maybe all of a sudden they have some vision loss or some numbness or weakness on one side of their body. Then you want to make sure that this person gets to the hospital as quickly as possible. Because remember, more than any organ in the body, our brains love oxygen. Brain tissue cannot live without it, even for a few minutes. So in a stroke, when blood stops flowing to a part of the brain and thus deprives the brain of the oxygen it carries, the brain tissue that's missing out on oxygen starts to die off. So super important that whoever you're suspecting of having a stroke is taken to the hospital as quick as possible to save as much brain as possible. So now that we're at the hospital, what goes on there? What's going to happen? Well, a few things are going to happen. So, the plan is to diagnose the stroke, right, with some tests and some imaging, and then to treat the stroke with some medications. So let's take a look. So we know that part of diagnosis includes a physical exam to look for any physical signs that the person has had a stroke. Really importantly, it also includes imaging like CT and MRI scans. And it includes lab tests, blood work to look for an underlying cause of the stroke or to rule out other diagnoses like hypoglycemia, which can look like a stroke. So the kind of treatment that the person gets really depends on the type of stroke that they had. So let me show you what I mean here. You could have had an ischemic stroke, for example, where a clot blocks off a bit of blood vessel in the brain and causes a stroke that way. Or you could have had a hemorrhagic stroke, for example, where a weakened blood vessel in the brain starts to leak, maybe because of a ruptured aneurysm or some trauma to the head, like from a fall or something unpleasant like that. But how does the type of stroke you have influence treatment? Well, because for ischemic strokes, which you can usually identify on imaging, actually, let me clarify that. You won't be able to see any brain changes on CT scan right after a patient's had an ischemic stroke. That's why the CT up here looks pretty normal. But the key is that it doesn't look like a hemorrhagic stroke CT scan, which I'll show you in a few minutes. So the patient in whom you're suspecting an ischemic stroke gets certain medications that you definitely do not get in hemorrhagic stroke. So let me show you what I mean here. And let me bring up a blood vessel here to just show you how these medications work. So if the patient had an ischemic stroke and came to the hospital quickly enough, they'd often be given two types of medication. So one is aspirin, and aspirin doesn't actually do anything about the existing clot. It can't break it up or anything like that, but what it can do is prevent new clots from forming. So it stops platelets in your blood from working properly, because platelets in your blood are responsible for forming the initial component of a blood clot. So it stops those from forming. And really importantly, you might be given a type of medication called a thrombolytic. And this thrombolytic is the one that can potentially break up that clot that's causing the stroke, right? So you might have heard of clot busting medication, and this would be a type of that. So thrombo means clot, and lytic means to break something up. And this one in particular is called tissue plasminogen activator, or TPA. And that sounds like a pretty confusing name, but it's called tissue plasminogen activator because of what it does. It activates a compound called plasminogen that's already naturally found floating around in your blood as part of the body's natural mechanism to break up any clots that shouldn't be hanging around. So TPA sort of kickstarts this natural system already in your bloodstream to try to bust up the clot that causes a stroke, right? And actually when plasminogen gets activated by TPA, it turns into this compound called plasmin, and that's what's actually doing the busting up, the clot busting. That's why I wrote plasmin here. And really importantly about this drug, the benefit of TPA is the highest right after the stroke has occurred, and then it just kind of gets less and less effective from there. So again, I'm just trying to highlight the fact that the earlier the patient gets to the hospital, the better the outcome, the better the TPA will work. So that's ischemic strokes. That's sort of acute management of an ischemic stroke. With hemorrhagic strokes, though, it's a different story, because when you have vessels that are bleeding out, the first thing you want is for it to clot off and stop bleeding, and therefore the last thing you want is to activate your plasminogen clot busting system. So you won't be given TPA, because if you are given TPA, then your blood will be far less likely to clot, right? As we saw earlier, and blood will just continue to pour out of this deficiency in the blood vessel here, see? And actually, let me bring up a CT scan of a hemorrhagic stroke. Remember, I said I was going to bring one up. So you can see all of this blood here. This bright spot is a big collection of blood that's been sort of leaking out of blood vessels in the brain that have ruptured. And so you can see that this looks really different from the CT scan over here on the left of an ischemic stroke. And so this is why brain scanning is super important when you're diagnosing a stroke, because it really has big implications on how you treat the stroke afterward. So for hemorrhagic strokes, the focus of initial treatment has to be a little different than with ischemic strokes. So for example, with hemorrhagic strokes, it's really important to find out which blood vessel is bleeding. So where exactly in the brain the bleed is. And that can be done by the imaging tests like CT or MRI or angiography that we talked about. Because the goal is to stop the bleed, so it's important to first know where it is. And another thing, anytime you're bleeding from a vessel, right, losing blood, your heart starts to get a little worried, right? Good old heart, always looking out for you. So it starts to pump blood out a little harder, and it's thinking that that's what it'll take to get blood going everywhere again. So now your blood pressure has gone up. But there's two main drawbacks to that. One is that if a little clot has started to form, right, to seal up the initial tear in the blood vessel, if that new, maybe not so stable clot gets hit with blood racing along at high pressure, it might get dislodged and re-bleeding might happen. The second drawback to blood pressure that gets too high is, well, let's say that a clot hasn't formed and the bleed is still bleeding, it's still active. Then now blood will just start coming out of the vessel even faster, right? And that's probably the last thing that we want. So the patient might be given antihypertensives or blood pressure lowering drugs to try to keep the blood pressure from getting too high. It's also really important with hemorrhagic strokes that the healthcare team stops or reverses the effects of any medication that the patient's regularly taking that might increase bleeding, such as warfarin or the aspirin that we mentioned earlier. Also really important is that pressure building up in the brain and the skull from all this blood is controlled. And for starters, one simple way to do that is to just make sure that the head of the patient's bed is elevated. And this works just because of good old gravity. When the patient's head is elevated, then more blood will flow out of the head in the jugular veins, right? So that's one way of lowering pressure in the head a bit. And one reason why keeping pressure in the head at a normal-ish level is really important is that when your brain starts to get pushed on or compressed, it kind of disrupts the normal electrical activity in the brain, and you could end up having a seizure. So the doctors might consider giving an anticonvulsant, which is a medication to prevent seizures from happening. And another reason is just because some pretty vital areas in your brain, particularly your brainstem, they might get compressed with all of this pressure building up, and that's pretty quickly fatal. So we don't want that. And there are some other surgical ways to keep pressure under control, but we won't focus on that right now. But you can definitely start to see that management of hemorrhagic stroke is really about managing the patient until interventions like surgery can happen. Whereas with ischemic strokes, while you might still need more invasive treatment down the line, at least you can give TPA initially to try to get things resolved beforehand, try to bust up that clot before you need sort of more invasive treatment. So that's a quick look at some of the immediate management of ischemic and hemorrhagic strokes. So really the main sort of underlying goal of stroke treatment is really to save as much brain tissue as possible, as you probably thought, right? Because by saving the maximum amount of brain tissue, the idea is that we only lose a minimal amount of function, right? Of bodily function, movement, vision, sensation, taste even. So you might remember that in any ischemic stroke, there's a core area of neurons right at the site of the blood vessel obstruction. So there's brain tissue there that'll usually be irreversibly damaged within a few minutes of losing their blood supply. So that's not great, but the good news is that there's salvageable brain tissue surrounding that core called the penumbra. So this is an area where blood perfusion has gone down because of the blockage here, but since it's still getting oxygen sort of peripherally from these blood vessels in the areas around it, these penumbra neurons don't die off right away. And if the person gets quick enough treatment, then the penumbra neurons don't die off at all in most cases. The penumbra is savable. So when someone comes in having had a stroke, the healthcare team often is thinking, all right, let's get down to business and try to save the core if possible, and let's definitely save that penumbra before it's too late. So with all that said, what sort of treatment can you get after a stroke? Well, remember that it depends on what type of stroke you've had, ischemic or hemorrhagic. And with ischemic strokes, you're usually given aspirin to prevent new clots from forming, and thrombolytics, which try to break up the existing clot. And with hemorrhagic, it's more about managing symptoms and potential complications in the initial phases of the stroke. Sometimes with an antihypertensive to lower blood pressure, and thus the amount of bleeding that's happening in the brain. And sometimes with an anticonvulsant to prevent any possible seizures. And sometimes with drugs to reduce swelling in the brain. So a few different medication options for these two types of strokes. But what else can be done? I mean, we've all seen McDreamy, the neurosurgeon, rush into the OR with his fancy hair and his "it's a great day to save lives" spiel. What's he up to? By the way, he's the neurosurgeon from the thrilling drama Grey's Anatomy. In the case of ischemic strokes, the surgeons won't usually be called to surgery unless the patient isn't responding to thrombolytics. So thrombolytics are usually tried first if the patient's still within the few-hour window that they work best in. Otherwise, if the surgeons are treating a patient with an ischemic stroke, they might be doing one of a few different but similar types of procedures with the ultimate goal of removing the clot that caused the stroke. So one little device that they might use is called the Mercy Retriever, and this was actually the first ever little gadget that was approved for clot removal after ischemic stroke. So let's look at what Mercy stands for to get an idea of how it works. Mercy is an acronym, right? So it stands for Mechanical Embolus Removal in Cerebral Ischemia. And how does it work? Well, let's just look at the general idea instead of bogging you down with all the technical details here. So essentially what happens is that as part of this procedure, a surgeon will insert a little wire into an artery and sort of thread it up into the brain, right? Guide it along the arteries and get up into the brain here. And then the wire gets pushed just past the clot. And that thing in blue there is actually a little sheath. The wire is actually inside the sheath. And then when the sheath gets retracted, the wire starts to actually coil up on its own. And then as the wire is slowly retracted, as you can probably imagine, it'll sort of catch onto the clot. It'll grab onto the clot nice and tight. And then the wire and the clot, together they're both removed. And now blood can perfuse this area again and try to save all this brain tissue here. So that's Mercy Retrieval. It's pretty cool stuff. And another way that ischemic strokes can be treated surgically is with suction. So how does that work? Well, again here, same sort of deal. A tube goes into the artery, and from here a little wire is put through the tube and positioned so it's right behind the clot. Then this tube sort of turns into a little vacuum cleaner. It starts to suck in. And while it's sucking in, a wire gets pushed back and forth a few times through this clot to break it up. And all the little pieces that break off, and eventually the whole thing, the whole clot, gets sucked into this little vacuum here. So that's the suction method. And so there's a few other little variations on these two procedures for clot removal. You know, some using little mesh tubes called stents, and some others with some different mechanisms, but I'll leave it at this for now. So those two that we just talked about, those are treatments for ischemic strokes. But if our surgeon was treating a hemorrhagic stroke, where one of the major goals is to control the bleeding, he might be doing some other things, some different procedures. So there's one called aneurysm clipping. And what that is, well, we know that if an aneurysm in the brain bursts or sort of ruptures, then it'll start to spill blood out into the brain space, right? Well, one way to fix that is for the surgeon to place a clip that kind of looks like this thing here, like it's like a metal clip that then gets clamped onto the base of the aneurysm. So now that clip has blocked blood from coming through here and spilling out. So now blood can just continue along its merry way, right? So that's one way to treat a hemorrhagic stroke, with these clips. Another procedure a neurosurgeon might do, and again this is in cases where a hemorrhage was caused by a burst aneurysm, is something called coil embolization. and in coil embolization, and you'll kind of see why this name is fitting in a minute here. The surgeon will insert a little tube into the arterial system again. We're back to the tubes again. So it'll get threaded up into the cerebral arteries until it's basically right inside the aneurysm, right at the mouth of the aneurysm. And then this flexible little wire gets threaded in through the tube, and it starts to now coil up inside the dilated out part of the artery, the aneurysm here. And then more and more wire gets pushed in through the tube and into the aneurysm, and it just coils and coils and coils. And eventually, blood now can't even really enter that aneurysm, right? Even if it wanted to. So two things. One, blood can now start to clot, right? It can start to clot onto all this material in the aneurysm here and stop any bleeding from happening. So awesome, thumbs up. And two, blood in this artery here now, it doesn't even have the option to duck up into this aneurysm and cause trouble anymore because of this clotted up coil. So now blood just continues to go about its business, I guess, down over this way. So double thumbs up. So those are some of the surgical interventions for ischemic and hemorrhagic stroke treatment.
The symptoms of a stroke can be pretty subtle and are often easy to ignore until it's too late. However, if promptly diagnosed, some of the stroke itself can be reversed with therapy that breaks up the blood clots that often cause stroke. But that means identifying the symptoms and getting to a hospital that offers therapy immediately. Philip Stieg is a neurosurgeon at New York Presbyterian Hospital, a nationally ranked center of excellence.
The major problem that we have in dealing with stroke is that the public is not aware and they do not seek medical attention rapidly enough when they do have a stroke.
Stroke is not as simple as a single set of symptoms.
The part of the brain that's affected, that will be where you manifest the stroke symptoms.
The first step is to know if you're a good candidate to have a stroke. These are the key risks: heavy smoker, strong family history, diabetes, high cholesterol, overweight, high blood pressure. Step 2, know the subtle signs.
Loss of vision in an eye, loss of speech, loss of motor function, loss of sensory function, loss of coordination, loss of facial function, loss of speech and swallowing.
Step 3, get an immediate evaluation. Your doctor will listen to your carotid artery for sounds that it is narrowed. The next step may be a carotid ultrasound, which bounces sound waves off the inside of this blood vessel to look for narrowing. If it's more than 60%, an MR angiogram or CT angiogram may be ordered. With a high degree of blockage, there is a benefit to opening up that blood vessel. The procedure is called an endarterectomy, which removes the blockage, or it can also be done with a balloon that breaks up and pushes the blockage aside and then replaces it with a sleeve called a stent.
Because we're using intraoperative EEG monitoring, smaller incisions, and better anesthetics, we can get you discharged from the hospital, home to your loved ones much more rapidly.
Choose a surgeon who does 50 endarterectomies a year with a total death and complication rate of less than 3%. The key is paying close attention to your symptoms and then acting as quickly as possible. Time is critically important. Review your risk factors with your doctor and the symptoms so that you'll recognize them. If these symptoms continue more than a few minutes, worsen, or you have new symptoms that appear, you'll want to call 911 to be transported to the nearest stroke center as quickly as possible. You only have 3 hours until the stroke begins to become permanent.
It's incredibly important for you to get to our emergency room quickly after you've experienced the stroke so that we can get the IV TPA into your system within 3 hours of the event. This will break open the clot and can save your life and your brain.
After examination in the emergency room, these are the appropriate tests. First of all, a CAT scan. You should have this CAT scan as quickly as possible to look for bleeding in the brain. The CAT scan is the best way to see the blood in the brain. If there isn't any bleeding, doctors give a clot-busting drug to break up the blockage that causes the stroke. The next test is an MRI that's given after the TPA. This determines if the blood vessel is still closed off or if it's opened up.
If that shows that your blood vessel is closed off, we use this clot retriever to pull the clot out of the blood vessel, thereby opening it up so that normal blood flow is returned to your brain.
This is done using a snare which is threaded through blood vessels in the brain to retrieve the clot. Stroke takes almost everybody by surprise. You have to do your homework ahead of time to be able to recognize the simple signs such as slurred speech or acute imbalance and immediately react by getting to a hospital that has clot-busting therapy and specialized care of stroke.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.